have a wonderful and talented speaker, Dr. Shelly Timmons, who's the director of Neurotrauma and Trauma at Geisinger Clinic. She's a native of Illinois. She was a valedictorian for our high school. She went to the University of Illinois and did undergraduate degree in biology, and her minor was in rhetoric. I was very impressed. She then did her residency in arguably one of the best training programs in the country at Semmes Murphy. We have a long tradition of alliance with Semmes Murphy. Both Christina and Anthony and Raoul did fellowships at Semmes Murphy, so I always considered our elder sibling training program. Where she trained there. She also did a PhD in neurobiology there, and has really risen up to the ranks of the national and international leader in neurosurgery. She's very active in women in neurosurgery, and she just became the head of the Washington Committee. So for those of you who don't realize, I mean, that's an inordinate amount of work. Because these are people that protect the interests of neurosurgery for reimbursement, for all these things, for a lot of time and effort. So we really appreciate you doing that. She's published extensively in trauma, has multiple book chapters and publications, and is a real nationally recognized leader in trauma and critical care. We have a new certification, ECAS certification in trauma. She's very involved with that. And we're very fortunate. She's really what we call the triple threat in neurosurgery, clinician and research and educational person. She then went from Memphis to Geisinger, where she was instrumental in starting a residency training program. We went through that process. It's a very tough process, and it shows incredible leadership to do that. So we're very fortunate to have Dr. Timmons here, a real leader in neurosurgery, and without much further ado, Dr. Shelly Timmons.
Thank you. Well, I want to thank you, Dr. Nanda, for inviting me down here. We've talked about coming for a long time. I'm glad I finally was able to make it, and I've really enjoyed spending some time with your residents, who are clearly an excellent reflection of all the fine work that you've done here. So today I get to talk about something that is the most near and dear topic to my heart in neurosurgery, which is traumatic brain injury. And I've been working with traumatic brain injury patients for my entire career. Since the day I got out of residency, I took over as the Neurotrauma Director and Chief of Neurosurgery at the Regional Medical Center up in Memphis, and worked there for a number of years, as Anil said. And I really want to just kind of give a 30,000-foot view picture today of where we are with traumatic brain injury management and treatment, and just talk about some of the issues that we face as researchers in the area and leaders in the field trying to figure out what's next for brain injured patients. So as you know, the GCS was developed in the 70s as primarily a prognostic tool for a TBI, and it gets used for a lot of other things nowadays, but it really was a tool that was based basically to predict mortality. And that has been something that we have relied on up until today as our mainstay of prediction and prognostication in brain injury. But we really need to move beyond that into far more sophisticated mechanisms of determining what is going to happen to these patients so that we can decide what the best interventions for them is. And so when you talk about prognosis, obviously we're trying to figure out how the patients are going to do, and that's the formal definition of prognostication. And I highlighted a couple of the phrases because I think they're important to think about for TBI in particular. So we think about survival and recovery from TBI as anticipated from the usual course of that disease, and I would argue that we don't necessarily always know what the normal course is for TBI patients, and as indicated by special features of the case. And that, I think, is where we really need to, as clinicians and researchers, focus our efforts to define what special features of TBI patients make them more or less likely to do well. So to talk about some of the things we can't change, I think is important to understand where we are with knowledge of demographics and pre-existing factors and so forth, as well as injury profiles and systems issues. So for a long time there was a thought that women tended to do better from brain injury than men, but that's been pretty well debunked. I think there are conflicting data. And part of that is, as we go forward, something that we really need to delve into in terms of what are the hormonal protections that might be at play. That's why the progesterone trial, which I'll talk about in a little bit, one of the reasons that progesterone was used as a basic science study drug in TBI was because it was felt that women did better. And so there's a whole history behind that and how that came about. Age, you know, for many of the early studies in brain injury, there were sort of these hard cutoffs where it was felt that if you were older than 30 or older than 40, you were going to do poorly. But really what more recent studies and meta-analyses have shown is that it's really more of a continuum of age, and it matters not exactly what the exact age of the patient is, but their comorbidities are much more important. Ethnicity, genetic background, those are issues that we're just now starting to scratch the surface of what types of patient profiles might make a difference for prognosis. As an example, there have been some studies on genetic polymorphisms that have looked at different patients who have different aspects of genetics, and they do make a difference in terms of outcomes in both animal and human studies. People with the APOE4E allele, for example, do more poorly than others. Comorbidities, again, we live in a society where these are becoming far more important in terms of how we manage patients, and certainly when patients are abusing drugs and alcohol, that may impact their outcome from brain injury. Obesity is a national epidemic, has become an important negative predictor. And then now that we have such an aging population who are on multiple medications, especially the anticoagulant and antiplatelet medications that we as neurosurgeons are so fond of, we have to deal with that as well. So in order to really understand prognosis from a specific injury, you have to tease all this out and sort of figure out what are the driving factors for prognosis. And then I think there are some other things that we don't talk about as often, but that are really, really important. And that's Bob Woodruff there, who you'll recognize. And the family support, education level, economic resources for rehabilitation, even something as simple as transportation to rehabilitation. There have been study after study that show that these things are important for community reintegration and functional outcomes. And that's something that we really have to think about when we're talking to families in the hospital. We see this, clinically, that the patients that have the family support there will tend to do much better than the ones who are left on their own. And then this is something that's just my personal viewpoint, which is that I think there is an element of cognitive flexibility and personality geared toward adaptation. So these are 3 of my patients who are happy people who have had brain injuries, who had deficits but really rose above those deficits and had really meaningful lives and went back to work and school and just learned how to deal with them. And that's sort of an intangible that we don't often think about, but is very operational, I think, in terms of how people respond to an injury or an illness. And for TBI in particular, if they can maintain that cognitive flexibility and adaptation, it really does make a difference for how they do in the long run. In terms of injury profiles, that's my little bored yawning cat there, because this is something we talk about over and over and over again, and I think we tend to get into this sort of rote recitation of GCS and pupils and hypotension and hypoxia as the only things that matter, but we'll talk about how there are so many more. But nonetheless, these things are very important, of course, on the front end in terms of determining prognosis. Randy Chestnut published in the early 90s from the Traumatic Coma Data Bank data that showed that hypotension and hypoxia individually significantly increased mortality after TBI. And then if you put the 2 together, it's really a 1-2 punch, and the patients do very poorly if they have both of those. And that's because obviously the injured brain has a need for blood flow, and blood flow is reduced in the first 24 to 72 hours after brain injury. And certainly if you have hypotension, hypoxia, you're depriving the brain of oxygen that it needs in that critical phase. So it's not surprising that these patients do worse than if they had not had those events occur. Certainly, polytrauma is something that has gotten a lot more attention in the last several years, not only because it impacts mortality, but if you think about what the outcome on the functionality of the person is, it really is important. Patients with limb fractures, patients with abdominal surgery, pulmonary problems that can't get even out of the ICU for weeks at a time, so they have those complications of immobility. These things all impact how they're going to do in the long run in terms of their ability to get back on their feet, back into the community, and back to a functional lifestyle. So I think it's important that we, in our models of prognostication, actually figure out a way to take all these things into account, which currently we really don't do other than through a score called the ISS, or Injury Severity Score, which does accommodate other injuries into prognosis, but not so much for functional outcome, more so for mortality. Craniofacial and neck injuries can obviously co-occur with brain injuries. The blows to the head that cause both are concurrent, and When it comes to neurologic recovery, it's important to query people about their ability to smell, to taste, to see, to hear, their balance, hoarseness, etc. And then facial injuries, of course, will sometimes dramatically impact people's sense of self, sense of personality, and their willingness to go back into a social situation. So that really does impact the way that people are able to reintegrate. And then finally, radiographic predictors. So this for the residents, if you've been involved in any research in this area or done reading, you'll recognize a couple of the next two landmark papers that I'm going to report. But the National Traumatic Coma Data Bank from the late 80s, there was published a paper about outcomes based on radiographic findings. Mass lesions, and the volume in particular, the mass lesion, subarachnoid hemorrhage, and midline shift in cisterns are the four most important predictors of outcome after brain injury on CT scans. Now, if you think about the history of CT scans, these were CT scans done in the 80s, and to have enough subarachnoid hemorrhage to be visible on a CT scan from the 80s, it had to be pretty significant. So it's not the patient that has the little smear one sulcus of subarachnoid hemorrhage that we see so many times today. This was really, truly significant subarachnoid hemorrhage. The presence of midline shift, we know, is inversely proportional to outcome. So the more shift there is, the worse the patients do. Compressed or absent cisterns and other lesions that are either evacuable or not are going to impact the ultimate outcome. And so based on those data, Larry Marshall developed a score called the Marshall Classification of CT scans, and it's listed in the top left box over here. Diffuse injuries and focal injuries were separated, and you can see the definition. And we talked earlier with the residents about arbitrary volume of lesions. This was truly arbitrary. 25 cc's was just a number. So some limitations of that, it does not take into account the subarachnoid hemorrhage that was noted to be associated with outcome. The volume is arbitrary. Doesn't take into account the type of hematoma, so clearly epidural hematomas have a much better prognosis than subdurals, and that wasn't taken into account. And it doesn't talk about the extent of basal cistern compression. So in response to that, and this is usually not used clinically, it's mostly used in research, but in response to that, Andy Moss and his group in Rotterdam developed a different score, which you see over on the right, that takes into account some of those weaknesses of the Marshall score. But again, it's pretty basic, and it's not really, able to tease out the difference in a patient that has, 6 lobes of parenchymal hematoma and subarachnoid hemorrhage everywhere, and IVH, and an extraaxial lesion versus somebody who has a less bad looking scan. Other things such as hormonal dysfunction from anterior skull-based trauma that might affect the pituitary gland, electrolyte disturbances for the same or brain tissue parenchymal injury, and coagulopathies. We don't really have any scoring system that incorporates those types of things into what we're trying to accomplish with prognostication. And then finally, system issues we know are important. So high volume trauma centers tend to have lower mortality rates. Transport times are important, and transport systems are therefore important. And then there have been several studies, too numerous to refer to, about access to rehab, insurance status, even proficiency with English in an English-speaking nation where rehab services are really centered on cognitive services, really make a difference in terms of how people are able to recover. So we know that these systematic issues have an important part to play. We talked a lot today about insurance status and the ability to even get people to rehab in the first place. And that's an issue because we know if people have access to those services, they do better. So in an attempt to formulate a different and more sophisticated means of prognosis, Andy Moss and the group in Europe that he works with developed another scoring tool, and this is it here. It's called the impact score. It's not to be confused with the concussion assessment. But you can basically, there's an online calculator, you can fill in the information that is shown here on the left, and it will generate a graph for you in terms of prognosis for survival on the right. And it's not to be meant to use as a standalone tool by any means or any kind of medical decision-making tool at the bedside, but at least it does give researchers a category by which they can dichotomize or stratify patients who fall into a certain category. So if you have, 10 patients who are between 20 and 25 and have similar characteristics on this, we have some idea what their mortality will be from their brain injury alone. And so this is something that started to come into play in the research world, and where people are trying to use this type of scoring system to see if the intervention versus the control actually makes a difference in their impact predicted mortality, not just their GCS predicted mortality. So one of the other things, moving on from things we can't change, I think one of the things that impacts how we do clinical research in TBI really has to do with how we define recovery. And there are objective measures of defining recovery, and there are subjective measures, and then there are patient values, and we'll talk a little bit about each one. But all of it has to do with functionality on a day-to-day basis, not just survival, because we have decreased survival from TBI in the 80s from over 50% as a general number down to about 25 or even 15% in some large studies. So we've made people able to live. Now what are we doing about making them have a better outcome and a better life? So the first thing to know about assessing outcome is to be familiar with some of the tools that we use as researchers in this area to see how people are doing. And by far and away, the most common thing that we use is the Glasgow Outcome Score, which you guys are probably familiar with. That is a 5-point scale. It's pretty coarse, and I'll talk about some specifics there. One way to extend the specificity of the GOS was to develop some subcategories, and that's called the GOSE. And then I listed some other tests that we frequently use in our neuropsychological testing to test different aspects of cognition, such as attention, spatial appreciation, memory, specifics about symptoms that are physical, such as headache, nausea, fatigue, those types of things. And we have to kind of use a combination of these tools to really see how people are functioning on a day-to-day basis. It's not enough to see them walking and talking and say, oh yeah, you're doing great, because their lives may be falling apart behind the scenes for a variety of reasons related to their ability to think clearly. So the GOSE I listed here, I won't read that to you, but basically it divides people into dead, vegetative, severely disabled, moderately disabled, and good recoveries. And you can see that some of the specifics of that, there may be wide variability within one category. And that's one of the limitations of the GOSE, because somebody who is talking, walking, no hemiparesis, able to interact emotionally with their family members, has their normal personality, but they have some kind of cognitive deficit that doesn't allow them to navigate, and they can't take public transportation or they can't drive, may be considered very disabled because they cannot get out in the workplace, they can't go out in public on their own. Whereas somebody who actually has a deficit, a big deficit, but can do those things may be considered a better outcome. So it really does have some variability to it, even though it's supposed to be an objective score. And if you look at how the GOSE is obtained, this is how it's obtained. It's a structured interview format. We all consider it an objective test, but it's really fairly subjective if you think about how we really gather the information. We have somebody interviewing the patient. They might be interviewing the family member. They use their judgment to decide who's the most appropriate one to believe, because a lot of times the patient will say, oh, I'm doing great, and their family member will say, this is the common thing I see in my office, right? They're doing terrible. So you have to figure out who's the right person to listen to. You have to judge whether mental obstacles are making them unable to do something versus really their brain injury. In other words, they live on the 5th floor of a walk-up and they can't get up and down stairs, but if they lived on the ground floor, they would be fine. And you have to sort out whether other injuries are preventing them from doing stuff versus their brain injury. So that limb fracture that I talked about earlier, is that the reason they're not walking, or is it their brain injury? So there is some art to this, and there's some experience level that people have to attain in order to do this accurately. And it's important to kind of know that in the background while you're reading papers that talk about the GOSE all the time, which you think is fairly numeric and discrete. And in terms of other functional outcomes measures, these are some other specific tests that we do to look at whether or not people are able to use their cognition effectively. And one of the things that we did, I was involved in NIH Traumatic Brain Injury Clinical Trials Network, and we did some neuropsych tests that were fairly sophisticated to look at outcome. And one of the things we try to do is combine some of these tests that have good inter-rater reliability, they have good objective data on their validity, and we tried to combine them in a single score that would hopefully help differentiate our placebo group from our control group in one large trial that we did. And we found that it really didn't help to do that. One test versus 10 tests, it really made not much difference. So we have to develop ways of understanding what these data from these neuropsych measures really mean. These are some of my neuropsych colleagues that I've worked with through the years, but I think we also have to understand that there are differences in common research protocols and settings where we're able to do a lot of these neuropsych tests and what we can really do in real life. So I don't know about you guys, but when I was in Tennessee, it was really hard to get some people to get neuropsych testing if they had no insurance. My problem where I'm in Pennsylvania is access. We don't have enough neuropsychologists that are skilled in doing this. So it's not as easy to do all this in a clinical setting as it is in a research setting at times. And we don't have really handy, easily available ways to compare progress. So if you're doing 15 different tests in a neuropsych battery on a patient at point X at 6 weeks, and then you repeat those at 6 months, you really have to read like a 6-page long report, and then you have to read the next 6-page long report, and there's really not a lot of good ways that you can easily derive whether the patient is improving in certain paradigms or whether they're not. So we have to develop those tools, I think, as we progress with our knowledge of how to best study these folks. And then finally, I think it's important to remember there are behavioral impacts on function that are not to be forgotten, especially with TBI patients. A lot of the patients have damage to the frontal and temporal lobes because of the skull base anatomy and the mechanisms of injury. And those domains that control behavior really are disrupted many times. And those may be the sole reason that the patient is unable to function in society, even though they look normal from the outside. So we have to figure out ways of assessing these types of things separately from the other more inflexible cognitive domains. Finally, I think patient values, we need to understand what is a good outcome to a patient may be different than what I think is a good outcome. And it's important that they really have a sense that they're supported. Their appearance may change, their relationship, their work, all these things that go into making us us that are impacted quite dramatically may be important to the patient's understanding of where they are in life. Many times judgment and insight is impaired, and it's hard for patients to even understand that they've made improvements over time. So I always encourage my folks to keep a diary or a journal and mark down where they think they are. And it's amazing to me how often I hear, oh, I didn't really believe you that I'd gotten so much better until I started writing things down. And then when I read where I was a month ago compared to now, I see I'm making a lot of progress. Because that part of your brain that tells you that you have made progress is just not functioning correctly. So those are things that we need to work on in terms of our understanding of outcome. I think we also have to have an understanding of what we're doing as we alter the course of the patient in the ICU and beyond, how that impacts the usual course of the disease, right? Because obviously what we do is making a difference. My personal philosophy in managing these patients, I think we do have to follow evidence-based guidelines. We have to have standardized approaches where it makes sense. Where we know what the right thing to do is, we should do that automatically. Where we don't, we have to tailor the therapy to the patient in front of us. So it's really important to know what their physiology is, to understand what their particular pattern of brain edema, of ischemia, of blood flow, of autoregulation, and tailor our treatments to those issues that are going on in the ICU to best impact their recovery. So these are just a series of the evidence-based guidelines that hopefully you all are familiar with. And if you think about what those are all directing us to, we're really discussing a series of actions, and these are our goals. So we're really we aim at reducing ICP, we're trying to maintain CPP, we're trying to avoid hypoxia, and avoidance of complications, which is really important. Our goals are really to prevent secondary injury, reduce mortality, which we've done quite dramatically in the last few decades, and now improvement in functional outcome. How do we do that? Well, typical patient right here, right? This is kind of what the patients in your ICU look like in your neuro ICU. Here's an actual picture of a patient from, I think that's from Columbia, I want to say. And I pity the nurse who has to get in there and take care of that patient. But this is what we're faced with. And how do we collect all this information and do all these interventions and really make it make sense on a day-to-day basis when we might be rounding on the patient for a few minutes in the morning and then off to the OR and responding to other things. So I think we have to develop tools to do that. Certainly multidisciplinary management is here to stay. We rely on our colleagues in all sorts of disciplines to help us manage this complex morass of data and intervention. And these are the types of things that are truly important in the management of the brain injury patient. You guys, we talked about protocols for TBI management this morning. And I said, you know, basically we follow the guidelines, and these are the kinds of things that we do in terms of trying to make sure that every patient is meticulously managed every day, every hour, every minute. And these are the things that we're tracking, and these are the things that we need to actually collect data on if we're going to do research on these patients on an hour-to-hour, minute-to-minute sometimes basis, and we have to have large computing systems in order to let us capture this information and then go back on the back end and analyze it. And that is something that's in evolution and has really only been in evolution for the last 10 years or so. We have hemodynamic monitoring that we use. We have, you know, catheters and lines and neuromonitoring equipment, all this stuff that we really need to be able to make talk to each other. And I don't know if you guys recognize this or not, but most of the commercially available monitoring systems for bedside cardiopulmonary monitoring don't talk to the ICP monitor, which doesn't talk to the LICOX, the brain tissue oxygen monitor. None of that stuff talks to one another, right? Because it's all industry, it's all proprietary, and it's hard to make those things talk to each other. There is a system on the market that does that. There are very few people that can employ that because they're expensive and they're hard to integrate into practice. So I think if we're going to be serious about our management of TBI patients in the unit, we really have to start thinking about how important those types of things are. Getting all those data put together and putting it in a heads-up display that makes sense to a resident coming by in the middle of the night responding to an ICP call. Well, what was going on with their oxygenation? What was going on with their labs? What's going, you know, you have to kind of integrate all that information very quickly, and you learn to do that. But it's important to have systems that help you do that, and I think that's where we need to focus a lot of our efforts going forward. So these are the kind of routine decisions that we make every day on patients. What are the physiologic and lab parameters? What's going on with this patient? Are they having dysautonomia, which can be an event that causes their ICP to go up and nobody understands why, but if you look at their other vitals, you see their blood pressure and their heart rate are going up and they're having a storm, and that's why their ICP is going up. So you have to sort of sort through all this stuff every day, all the time. And then there's the other part of decision making, which is reactive, which is what do I do? You know, I have this information, now what do I do about it? And that's the kind of thing that I think we really need to make much easier for our bedside clinicians if we're going to make headway in this space. And again, you know, our approaches to treatment are going to affect the course. If you think a patient's going to do poorly and you don't pay any attention to them and you don't really do much, guess what? Self-fulfilling prophecy, they're going to do poorly. If you're aggressive and you're meticulous and you employ every intervention that you can employ to try to save the patient and save brain, which is really what we're talking about here, then you're going to have patients who do better. And we have to be really careful, I think, about being in this self-fulfilling prophecy of, well, you know, they're just going to do badly and I'm not going to do anything. Our neurosurgery care, we know from Randy Chestnut's study in South America that it may not matter exactly how you do that meticulous attention to detail as much as that you do the meticulous attention to detail. As you know, he studied ICP monitored patients versus those who were monitored with a clinician at the bedside nearly 24/7, frequent scans, frequent assessments, and really making a clinical judgment about their ICP, and they did about the same. Not at all an indictment of ICP monitoring, but just pointing out that if you're very attentive and you're aggressive about managing patients, you're going to have better outcomes. The quality of the overall trauma and critical care in the system really makes a difference. Early nutrition, early PEG, early trach, those types of things, avoidance of systemic complications, bedside nursing care, and again, quality rehabilitation. All these things matter in terms of how the patients do. When you're faced with a patient in front of you who has an ICP problem, we're always looking at these types of issues, and if you look at each one of these bullet points, A lot of the research these days is focused on more specifics of these bullet points, trying to figure out what the role of ischemia is, what's the role of seizures. And I think that's good because that gets us away from these large-scale studies where we're just throwing all these people in one boat and saying, well, here's 1,000 patients with a bad brain injury. Let's give them drug A or drug B and see if it works. Well, it hasn't worked. We've spent billions of dollars, and that approach has not worked. So I think we really need to start looking at individual responses to treatment for specific complications of brain injury. We know ICP matters. ICP is why, what we pay a lot of attention to. And the total time of ICP elevations is correlated with outcome. We know mortality is increased when ICP is not controlled, and that those patients who die often die with uncontrolled ICP. So that's why we monitor. It's not because we just want a procedure to do in the middle of the night. It really matters for how the patients do. But I think we have to think about our approaches to neuromonitoring. It's not enough to just throw a bolt in and watch their ICP or maybe their CPP and not think about how those events are linked to other things going on with the patient. So O2 desats from mucus plugs, whether we're bathing or turning the patient, making their ICP go up. All those types of things, we really have to have a way to document in the chart that's easily accessible, timestamp it, link them together, and then use that for our research going forward. And there are, again, systems out there that can do this, but not in widespread use. And I think we really have to start thinking about how to propagate these types of approaches in every ICU and every hospital that takes care of these patients if we can. There's some unique approaches that are being done in terms of research. And I think one of the things we don't understand is what individual variability exists in structures of the brain. And so the imaging research that's being done to look at what, for example, the size of the temporal lobe or the volume of the cerebral peduncle, et cetera, how that variability occurs in normal populations is going to make a difference for how we study people who have been injured in terms of their recovery. So that type of work is ongoing in a variety of arenas, and I think it's important that it does. This is just an example of one of the groups at UCLA who's working on brain connectivity. And again, when you're talking about a complex injury like a brain injury, where you don't see a lot of structural damage, yet a person is completely devastated and non-functional, we have to understand really the connections and the pathways in the brain. And that type of work is really important as well. I think we really have to think about our approaches to descriptive diagnoses and be very, and here's my rhetoric background, Neil, but I think we have to be very careful about the words we choose to describe the particular injuries that we're talking about. So we need more precise anatomical localization with imaging. It's not enough to just say, oh, they have huge bifrontal contusions, which is, I'm guilty as anyone else of saying these kinds of descriptions, but, is the contusion in the gyrus rectus, for example, is that going to affect their ability to taste and smell and so forth? I think we really have to start thinking about how to document where the injuries are on imaging. Our neurophysiological information needs to be better codified, and we need a better recognition of the sequelae of brain injuries such as dysautonomia, which oftentimes goes undiagnosed by providers. We need more precise outcomes, like I talked about impact of the brain injury on the function of the patient versus other injuries, and codification of detailed cognitive and other neurofunctional tests. So as we evolve these things, and they are evolving rapidly, which is great, we will have a better lexicon that we can share, that we know what we mean when we talk to it about a patient to another researcher, another clinician. And I want to talk a little bit about neurosurgery involvement, because I think this is another thing where sometimes we end up failing the patients on some level. So if you talk to patients and their families, the one thing that they really will always say is, I want to talk to that doctor that I talked to in the ICU, because they know, they understand that we have brain expertise, that we understand the cerebral function, that by dint of our training and experience that no other provider can do. So I think that we're well respected by the families. I think they do want to talk to us, and it's important to spend time listening to what they say about what's going on to the patient and explain what you can about the anatomy and what we know and what we don't know. And I think it's very important to be frank with families about telling them what we don't know, especially early on, because we know that we're poor predictors That's been studied and proven over and over again. So I think it's key for us to be involved in their care and their follow-up, to exhibit that compassion that gets us up in the middle of the night to go take care of them in the first place, and to follow them because we've been there from the beginning. And that seems to really make people feel better when you have that long-term follow-up. The other thing I think it helps with is a recognition of some of the neurological problems that patients often have. And if you think about it, if you're looking at a patient from the point of view of a neurosurgeon and you identify deficits that someone else may not identify, you might be able to think of a neurosurgical intervention that would help them. And I think it's, I sort of called it the reverse Hawthorne effect, but it's really sort of patient educating physician, or eyes on the patient, really identifying a problem. And then we can continue to attempt new treatments that maybe haven't even heretofore been thought of. And our personalities are geared toward intervention, so we see things and we want to fix them. So I think that's really, really key to our ongoing involvement. It's not necessarily economically rewarding for us to do that, but I think it is important, and it's very personally rewarding to have that long-term relationship. So in terms of things that are being done to try to help people after their injury, there has been a lot of interest in the 90s and even some into the early 2000s about neural transplantation and helping tissue regrow. And I think there's been a very large body of work in that area that has sort of fallen off in favor of other interventions and other treatment. And maybe we'll talk about transcranial stimulation at dinner tonight. But this is one thing that was tried early on that really shows some promise, but it hasn't been yet. It's not, I think it's sort of not ready for prime time. We don't know enough about what the optimal areas to target are, et cetera, but there's a lot of ongoing basic research in this area that's important. Interventions that might produce changes in terms of plasticity. This is just a new field in terms of the imaging that we're able to do. This is an example where patients, both normal subjects and patients who had TBI, went through a balanced rehab program, and then there was some tractography and some volume assessment MRI done, and they showed that the cerebellar peduncle volume changed in both normals and TBI patients after they went through rehab. So what does that mean for an individual patient? Don't know yet, but it's early stages, and these are the types of things that are important to study. Neuromodulation. Functional neurosurgery is probably one of the main contributions that we're going to be able to bring to this patient population. So we know these patients have spasticity. We know they have chronic pain. They frequently have tremors and other movement disorders. Even appetite derangement, mood, memory, and learning are starting to be targets of neurosurgical functional procedures. So as we go forward, I think it's very important to study these folks and to think about offering these interventions as they get approved in other areas. If we're starting to do stimulation for depression, for example, depression is 50% of these people will become clinically depressed. Maybe they can be helped by those types of interventions. And if we're not seeing the patients in clinic and we're not thinking about those things, we're not going to be able to offer that to them, right? So I think we really have to set up systems of care that allow for that. And then, the future, restoration of function, brain-machine interfaces, and so forth. There's not really a lot going on in this space in terms of traumatic brain injury, but there are other things happening in spinal cord injury and other fields where people are starting to learn how to use computers and use electrical stimulation to control areas of the brain, which hopefully in time will then become translated to TBI. So what happened? Please don't close. Let's go back. I want to just talk about a couple of the large-scale clinical trials that have been done recently. And there haven't been that many, sadly. For the reasons that I talked about, which is that basically lots and lots of money has been spent, lots of trials have been conducted, and I've been involved in a number of them. They're very complex, very time-consuming, very expensive, and very difficult to show any effect. And one of the reasons for that we talked about is grossness of outcomes measures. We're not measuring fine enough differences in patients. One of the other big reasons for that is heterogeneity of the patient population. So we're throwing a whole bunch of people with a whole bunch of different kinds of physiology and different structural injuries and so forth into one pot and calling them the same. And as we go forward, we really need to develop different research strategies because this has not been a strategy that has afforded us any successes in recent years. So there have been really about 4 large-scale publications in the last year to 15 months in TBI. These are 2 of them. These were the progesterone trials that I referred to earlier. Progesterone was selected because there's a large body of evidence in the basic science and preclinical research arena that showed that it was protective to animals, and even in phase 2 trials that it was safe and potentially effective in humans. The reason for that is that it's felt to be a so-called pluripotent drug or a dirty drug where it does a lot of different things. It reduces inflammation after brain injury in preclinical studies. It reduces edema, vasogenic edema. It can help reduce excitotoxicity and prevent apoptosis. So all these things have been shown with progesterone. So that's why it was selected as a target of large-scale studies. So these results came out fairly close together. The top study was sponsored by NIH, and this was sponsored by the drug company that makes the progesterone formulation. And the results were as follows. So the PROTECT-3, the NIH study, I won't read that to you, but that was the inclusion. And there was no difference in the GOSE at 6 months. In the Synapse sponsored trial, there was no difference in the GOS at 6 months. The NIH trial attempted to mitigate some of the issues that have been identified in prior TBI trials by doing the following. They had good preclinical data. They know that the drug crosses the blood-brain barrier, and so it actually gets to the target organ, which is important because some of the drugs we've studied in the past didn't. The timing was only very short, given within 4 hours, because we know that earlier that you give a neuroprotective agent, the better. And standardized protocols were employed, and I have asterisks there to talk about that. The outcomes measures were used, fairly gross, again, GOSE, and the stratification dichotomy was used where they were trying to see a difference within impact category, not a GCS3 patient versus a GCS12 patient. You know, if you're going to be a 12 and you're going to get a good outcome, you don't have far to go. If you're going to be a 3 and you want to get a good outcome, you have a really long way to go. They tried to use a predictive model where they used impact and said if you're a 3 and you have this, that, and that, this is your likelihood of doing well or poorly, and that's the statistical analysis that they did. So they did do a lot of things to try to make it optimize the likelihood of a good outcome. Standardized protocols, I will say, have been used not just in this trial, but in other ones in multi-center trials, including a number I've been involved in, and they're always difficult to pinpoint in terms of why there are center differences. And in my NIH network that I referred to earlier, we looked at center differences in mortality in our study, and we had very close adherence to our protocol, very detailed protocol, center differences. Couldn't figure that out. We never did sort of figure it out, but it's seen over and over and over again. So there are all those intangible things that we talked about, all those little details of treatment and so forth and approach. I think those are the things that really make a difference for center differences. Even though you think you've standardized things, it's still very hard to do. So I know I'm running out of time, so I'll wrap up. But basically, the investigators really attributed reasons for failure to show effect, again, to heterogeneity of injury, to heterogeneity of comorbidities, and to as yet undefined or defined individual characteristics of patients that we don't really understand. And I would add that I think, you know, for years we looked at these pluripotential drugs as a good thing. We thought, well, maybe that's great. We're going to be able to use some drug that it targets a whole bunch of different bad pathophysiological processes, but maybe what we really need to do is target our therapies to specific processes in specific patients, and then we'll be more successful. There's been one paper recently on hypertonic saline. This was a retrospective database study done by Roger Hartle, and was really looking at the New York Neurotrauma database. And it's a very limited study, but what it did show is something that I think we've often all observed in clinical care, is that when you use hypertonic saline, either, and this study was comparing it with mannitol, one agent, not together. But when you use it, the ICP intensity of care, the level of care that is required to manage ICP is less. And they showed that in their group in this retrospective trial. And then finally, Claudia Robertson and her group just published a study on erythropoietin and transfusion thresholds. This is a common question that we always get: what's the optimal hemoglobin level for brain injury patients? And this was a very well-conducted study. If you know Claudia at all, she's an excellent researcher and very meticulous. The one thing that I would say, there's a couple limitations to this, however. It was a 2x2 design. Patients either got placebo or erythropoietin, and then they had different transfusion thresholds. So there were 4 treatment groups, and they are as such. So we had EPO with a transfusion threshold of 7, placebo with a transfusion threshold of 7, and then 10 respectively. The problem is that they didn't really analyze this group versus this group. They lumped all the placebo patients together and compared them to the 2 treatments. And I think what I would have been personally interested in is seeing the placebo group and the transfusion thresholds and the difference in outcome. So they didn't see much difference in outcome across the board. It was a small number of patients, which did limit its utility and its broad applicability. So I think this didn't really answer anything for us in terms of transfusion threshold, although it did tell us that EPO probably isn't neuroprotective necessarily. They did use, again, the impact prediction of poor outcome in their covariate analysis. And again, it was small numbers. And it was really powered for really big treatment differences, which they didn't see. They did see a trend toward better outcomes in a higher EPO dose group, but they had to reduce the dose of EPO because of a stroke study that showed higher complication rates at that dose. So the study was changed in the middle, and that was cited by the authors appropriately as a potential limitation. So I think in terms of research, our approaches really need to transition away from the case series and meta-analyses, and maybe even transition away from randomized prospective trials. And we need to start thinking about different ways to do research in TBI. One thing that we think may be really important is to try to collect data, a lot of detailed information in these large databases, which are more uniform and standard, and share pooled data. And the impact group in Europe is one such way of doing that. We have some other data sharing collaboratives in the United States. We need to incorporate continuous neurophysiological data. We need to target our questions and/or our patient populations more specifically, and use advanced analytics and computing that we have the power to do to really bring to bear on this question. So I think we've been successful in the last decades in reducing mortality, and it's now incumbent upon us to think about ways to improve functional outcome by using more sophisticated data and taxonomies, more extensive involvement in the long-term care of these patients, and better research design and feedback for prevention efforts in the community. We need a paradigm shift. We need to get away from some of these gross prediction measures, gross outcomes measures, hand off to other specialists for long-term management, and get away from these large sample size studies probably in which we continue to fail to see differences, and move to targeted studies using all of our tools, but with neurosurgeons centrally involved in the design and execution of these research protocols. So thank you very much for your attention. Appreciate it.
Time for a few questions.
Not always, but more and more. So some of that is really related to the care environment where I am, and we talked about that with the residents. I think you really have to employ new technologies in a way that makes sense for your institution and use it responsibly. So when I first went to the institution I'm at, we didn't have the residency program, and we had 250 different nurses who might be caring for our patients, and as time has gone by, we've honed down the patients into one smaller unit. We have residents who can do some of that critical thinking in the nighttime and even during the daytime, and start to really make it make sense. So we use them in almost all of our severe brain injury patients, not 100% yet, but we're approaching that.
What's the take on patients with diffuse axonal injury? I mean, here are patients that don't have high ICPs, and you look at their CAT scan consistent with the exam, and then you examine them for several days, and they don't get better. And what's your take on what can be done to improve their outcome in the long run?
So I don't think we know that yet. I think you have to give them time, and for sure what we know is that those patients take a long time to get better, and there is a certain percentage of them that will. It may be weeks or months down the road, and the key there is complication avoidance, and to support them and get them trached early, get them pegged early, continue to move them. And there's a lot of interesting research now in like positioning and different areas of sort of just care of the body and avoiding the complications of spasticity and so forth. And I think you just have to give them time. I don't think we know the answer yet on who to tell, this is futile and we should not really do this, or we should, because we've all had cases like that of these young patients who have ultimately done well, and then you've got a whole bunch of people that haunt you that have not. And I think we really have to use our imaging techniques and so forth to try to tease that out. I don't think we're there yet.
Do you have any experience for microdialysis in severe TBI?
I personally don't. I think, but in terms of the utility of it, I think it's a great research tool. When you're trying to figure out who's really got tissue ischemia and who doesn't, it's important to use that in a research protocol. There's always the question of, well, that's a focal measurement. Is this a focal phenomenon or is it a global phenomenon? This whole brain ischemic. But it does tell you a lot about, lactate pyruvate ratios will really tell you a lot about whether the brain is ischemic or not. I think it's cool. It's important to do more and more studies using that and brain tissue oxygenation and jugular venous saturation and ICP, and try to coordinate all those data points together and really figure out ways to tease out which patient might have A physiology versus B versus C, and how we can best manipulate those things. Yes, sir.
You redefined attention to detail. It's wonderful. And one small point, like you mentioned nutrition. Without some of the essential vitamins, none of that serve as coenzymes, none of the neurotransmitters are working, and the brain will go into a slump regardless of what you do.
Right.
So you wonderfully covered the details of
That's critical. That's one of those things that we know we have to do, but sometimes we don't do well.
It's an all-court press.
Right. Right.
What do you think about the ICP trial? The South American thing. I thought, if ICP monitors cost $10,000, like one medical group, insurers would not pay for ICP monitoring,
Right.
because they would say, well, there's no benefit. The South American trial says there's no improvement. But since ICP monitors don't cost that much, there haven't been that much objection.
Yeah, I think it has to do too with our understanding of what that does for us. So it really was a trial of a clinician at the bedside versus a machine at the bedside. That's really what that study boiled down to. And a clinician costs much more than a machine. And the repeated CAT scans, and they did a lot more scans and so forth in those patients that didn't have the monitor. So I think it highlighted that we have different tools and we can do as well with certain combinations of certain tools, but we really probably need to employ all of them.
That's a very succinct way of putting it. Thank you so much.
Yeah, thank you very much, you guys.
Quick digression. I want to welcome Dr. Ashish Sonic, who's one of our fellows, who's researched with us, just visiting us, interviewing with us. And then we have a quick digression. We had a nurse with us that's worked with us for 27 years, Shirley Bullard, who's retiring, and has done an enormous job with all the residents. It's like being a mega babysitter and keeping all our residents in line, and she did a phenomenal job. So we have a little recognition for you, Shirley. Please come up and... Have a little picture, yeah. Anybody can put up with the residents for 27 years gets a Purple Heart.